So this morning, for our first talk, as I mentioned, is going to be Dr. Rice talking about some perioperative nutritional needs. So Dr. Rice, let me hand the camera and the mic over to you.
Perfect. Can everybody see my screen okay?
We can.
All right, so my name is Olivia Rice, and today I'm going to be talking about perioperative nutrition in the setting of non-elective orthopedic surgery. I have no disclosures. So personally, when I hear the term patient optimization, I think of preoperative counseling in the setting of elective surgery. Unfortunately, this type of preparation isn't always possible when urgent or emergent intervention is required. But while researching this topic, it became obvious that there are both pre-op and post-op components of optimization, peri-op nutrition being one of the most feasible to implement, which is why I'm focusing on it today. A growing body of evidence has illuminated that patient nutritional status significantly is correlated with surgical outcomes. Malnourished patients experience 3 times more post-op complications, including mortality, non-union, and major wound complications within a 12-month post-op period compared to their nourished counterparts. While baseline nutritional status is out of our control in the setting of non-elective surgery, supplementation within the immediate pre-op and post-op timeframe is modifiable and dictated by us. So what's nutrition's role in the perioperative period? Any significant injury leads to a hypermetabolic and catabolic state, where nutritional needs are significantly increased and 2 inevitable nutrition-related barriers to healing develop. One is the activation of the metabolic or stress response to injury, and 2 is the development of protein energy imbalance. The metabolic response to injury or surgery is a natural host response, acting as an amplification of the fight or flight sympathetic response. Hyperglycemia and insulin resistance are central metabolic processes to the stress response, and the severity is directly proportional to the magnitude of the injury or operation. This results in an exacerbation of the existing post-op catabolic state with marked loss of body fat and protein stores. On top of that, appetite can be suppressed by pain, medication side effects, and nausea, leading to inadequate calorie and protein intake. This means that after trauma or surgery, there's a time period where demand outweighs supply for nearly everyone. Further perpetuating the problem, patients with limited mobility are less active, leading to a negative feedback loop of decreased muscle protein synthesis and resultant skeletal muscle wasting, which can limit effective rehabilitation. This important concept of post-traumatic malnourishment is important since it implies that all trauma and surgical patients can benefit from some sort of nutritional supplementation. The obese surgical patient represents a unique nutritional status, and there's a growing body of evidence that they should not be overlooked. This population is often neglected because of a false assumption that they have nutritional reserves due to their adipose tissues. But in fact, obesity does not protect from malnutrition, and they are at high risk of protein and micronutrient deficiencies. All right, so on to treatment. Many of these concepts I'm about to discuss with you were first introduced by ERAS, or Enhanced Recovery After Surgery, which entails a multimodal perioperative plan of care, including a nutritional component, which has been shown to improve outcomes in surgical patients. So the big picture purpose of all of these interventions is to overcome or correct malnutrition by diminishing the metabolic response to surgery and injury and correct any protein energy imbalance by supplementing the patient with the essential nutrients required for healing. Also, while listening to this evidence, I just want you to keep in mind that all of these studies treated all of their surgical patients with nutritional supplementation in the intervention group, not just the patients identified as malnourished preoperatively. So first we'll talk about carbohydrate loading, which takes place in the 24 hours preceding surgery. From a physiologic perspective, its purpose is to minimize pre-op fasting and decrease proteolysis, and even more importantly, trigger a slow release of insulin to combat the post-op insulin resistance seen in the metabolic response to surgery. There are patient-reported benefits as well, including reduced preoperative hunger, thirst, and anxiety, as well as clinical benefits such as post-operative nausea, vomiting, and pain. The important components of any pre-op carbohydrate drink is isoosmolarity, which ensures swift clearance from the stomach, and complex carbohydrates, i.e. not just sugar, to slowly release insulin. The Ensure pre-surgery drink is currently being used at Atrium in the elective outpatient surgery setting, and patients are instructed to drink 2 bottles the night before surgery and 1 about 3 hours before surgery. This drink is in compliance with scope anesthesia's most recent MPO guidelines. However, it's probably in your best interest to discuss it with the anesthesiologist beforehand, since they still suggest 8 hours of MPO time before surgery to provide flexibility. Unfortunately, this Ensure pre-surgery drink isn't yet available in the inpatient setting as an order yet, but hopefully will be soon. To circumvent this, general surgery teams using ERAS have incorporated Gatorade into their pre-op order set, and the patient receives it around 10 p.m. the night before surgery when they're admitted for an urgent procedure. While this is likely better than nothing, there's little published evidence to support the use of sports drinks or juice in the place of a formulated pre-surgery drink. And as you can see here, the nutritional contents are not equal. So according to a systematic review from 2014 that compared pre-op carbohydrate loading to standard pre-op fasting, carbohydrate loading reduced postoperative insulin resistance by 50% without any delay of gastric emptying. Furthermore, 2 general surgery studies on the topic showed minimized loss of lean mass and muscle strength after abdominal surgery. It's worth noting that the majority of research on this topic includes patients without diabetes or any medical condition that compromises gastric emptying. While recent studies have shown it's safe in diabetic patients, whether pre-op carb loading is effective in this population requires further investigation. The next nutritional supplementation option is immunonutrition. This is an umbrella term used to describe nutrients that activate the immune system. Nutrients that fall under this category can improve or increase immune function and decrease the body's inflammatory response. While a number of nutrients can be considered immune modulating, the most common nutrients found in medical formulas include omega-3 polyunsaturated fatty acids derived from fish oil, antioxidants, amino acids, specifically arginine. Commonly seen in the post-op setting, an inadequate supply of arginine adversely affects T cell function, causing immune suppression. Its deficiency also impairs production of nitric oxide, negatively affecting microcirculation. Immunonutrition has some of the most compelling evidence of all of the peri-op nutrition supplementation options, so listen up. A meta-analysis by Drover comparing immunonutrition versus no supplementation in patients undergoing elective surgery found a 40% reduction in total infection-related complications and a 2.38-day reduction in hospital length of stay. They found no difference in mortality between the groups. In the same study, importantly, for the setting of non-elective orthopedic surgery, the settings of infection-related complications and hospital length of stay persisted in their subgroup analysis of non-GI studies and supplementation given in the post-op period only. So immunonutrition is likely superior to no supplementation. And interestingly, data from a multi-center general surgery RCT by Moya and colleagues showed that patients who used immune modulating formula for a week before and after GI surgery significantly decreased infectious complications, even when compared to a high whole protein control formula. So there's something specific about the combination of arginine, omega-3s, and antioxidants that seems to specifically combat postoperative infection. Speaking of protein supplementation, another nutritional supplement studied in the peri-op period is amino acid supplementation. The response of muscle protein synthesis following ingestion of free essential amino acids is more than twice the response to consumption of a comparable dosage of whey protein isolate. Therefore, essential amino acids have been most studied in the setting of exercise, including rehabilitation after surgery. Conditionally essential amino acids, on the other hand, specifically arginine and glutamine, are typically used for immune support, such as immunonutrition, and to support wound healing by enhancing collagen formation. Juven is a specific supplement containing a combination of calcium HMB, a leucine metabolite, plus arginine and glutamine. Another CEAA product is made by a company called Mend, which was actually started by an orthopedic surgeon and is available for anyone to order online. A 2020 RCT out of the total joints literature showed essential amino acid supplementation significantly reduced postoperative quad and hamstring atrophy 2 weeks after a total knee replacement. Similarly, a 2015 RCT evaluating Juven showed preserved strength in the intervention group 2 weeks after their total knee surgery versus significantly diminished strength in the controls compared to baseline pre-op quad strength. Most relevant to the non-elective setting, a previous mentor of mine at the University of Iowa just completed a randomized controlled trial in the ortho trauma population, including 400 patients and randomizing half of them to receive post-op Juven for 2 weeks after surgery. They found that the CEAA supplementation significantly decreased mortality, non-unions, medical complications, and hospital length of stay in the intervention group. For completeness, I also want to briefly review the postoperative vitamin and mineral supplementation as well. So calcium plays a critical role in many physiologic processes, including bone turnover and mineralization. Its efficacy in patients with osteoporosis, especially in preventing fractures, when given with or without vitamin D, is well known and documented by a meta-analysis in Lancet in 2007. However, its safety has recently been called into question due to findings of increased cardiac event risk, especially myocardial infarction, in the setting of supplementation. Vitamin D is commonly prescribed alongside calcium since it increases calcium absorption from the intestines and has separate independent effects on bone health as well. Its use in fracture patients gained popularity after Brinker released his landmark paper stating that vitamin D deficiency correction successfully resolved a few non-unions without additional intervention. Most animal studies examining the role of vitamin D have shown a positive effect on fracture healing, including increased callus volume, density, and mechanical strength. Clinical data, however, is sparse. In a systematic review of vitamin D supplementation in fracture patients published in JOT in 2016, Sprague et al. Found that many patients have low vitamin D levels, and supplementing them effectively repleted their lab values, but it was unclear if vitamin D replenishment affected success or speed of fracture healing. So what about calcium and vitamin D supplementation together? A nationwide population-based retrospective cohort study out of Korea from 2009 to 2018 assessed the risk for arthroplasty revision between those taking vitamin D and calcium for greater than 1 year compared to no supplementation. After adjusting for confounders, calcium and vitamin D significantly reduced revision risk by 44% after a 6-month drug use lag period. Additionally, implant survival was significantly improved in the calcium and vitamin D combination users compared with the never users. The only randomized controlled trial published to date on this topic was out of Denmark in 2003. They evaluated the healing process of conservatively managed proximal humerus fractures in osteopenic or osteoporotic women using bone mineral density scans, comparing those receiving calcium and vitamin D versus placebo. They found a significantly higher trend in bone mineral density, and by week 6 observed a significantly higher absolute bone mineral density level in patients receiving the intervention. So vitamin K, many of us are familiar with vitamin K1, which is responsible for the activation of enzymes involved in the clotting cascade. However, I'm guessing very few of you are familiar with vitamin K2 or menaquinone, unless you've heard me rambling about it in previous weeks. Vitamin K is an important cofactor for carboxylation reactions body-wide. This is indeed vitamin K1's role in a clotting cascade. Similarly, proteins involved in calcium homeostasis and bone metabolism, specifically osteocalcin and matrix globin protein, or MGP, also rely on vitamin K dependent carboxylation for activation and appropriate function. Interestingly, these proteins seem to have a particular affinity for vitamin K2 as opposed to K1, and they are intricately involved in calcium homeostasis as it relates to both vascular calcification and bone mineralization. When K2 is abundant in our body, it has the capability of activating MGP and osteocalcin, so they can bind calcium and move it out of soft tissues like arteries and into bones, respectively, thereby preventing and even reversing atherosclerosis while building bone density. Similar to vitamin D, a high percentage of Americans are deficient in vitamin K2, and many studies have shown its ability to increase bone mineral density and prevent fractures in the setting of osteoporosis when supplementing with K2. Additionally, it's been shown to reduce coronary calcification and coronary heart disease. While no studies have evaluated its effects on healing after orthopedic surgery, its role in vascular bone crosstalk and high prevalence of deficiency make replenishment of this vitamin an enticing target for both bone metabolic diseases and potentially fracture healing as well. So there's not enough time to cover research in all the micronutrient deficiencies, but to summarize, our physiology is complex, and while many preclinical studies show that correcting micronutrient deficiencies significantly impacts healing after injury, clinical studies are limited in number and their effects require further investigation. So even though this seems like a lot of stuff to add to our order sets, the good news is that there are multiple surgical subspecialties already using the nutritional supplementation options available to us at Atrium. In fact, our CNSA colleagues have started implementing post-op immunonutrition as a pre-checked option in their moderate and high complexity surgical spine power plants. In general, our general surgery colleagues who are national leaders in ERAS have been providing their patients with peri-op nutritional bundles at their pre-op clinic visits for some time now and are excellent resources for us to learn from. The vascular team has utilized Juven, the CEAA supplement, specifically to assist with acute and chronic wound healing in their high-risk patients with critical limb ischemia. And finally, all orthotrauma fracture patients are prescribed vitamin D and calcium at discharge. So what does implementation look like? Dr. Shu and the orthotrauma team recently met with Sarah Bender from CNSA and Felicia Dobkowski, RDN, to roll out perioperative nutritional supplementation with orthotrauma patients, similar to CNSA's active program. The plan is to utilize the inter-immunonutrition supplement for 5 to 7 days post-op, and then if desired, send the patient home with Juven for 2 to 4 weeks. The immunonutrition supplements could be given to the patient in bulk post-op, so the cost could be bundled in their hospital stay, but the cost of Juven may be a barrier to compliance for some of our trauma patients. So perhaps like vascular, we could consider the supplement is severely malnourished patients or those at high risk for wound complications and apply for some funding for that purpose. But implementation doesn't have to mean system-wide adoption and change. If you want to start personally ordering nutritional supplementation for your patients, all you have to do is order it in Cerner. And if you're super excited about it, emphasize its importance to your floor nurses and patients after surgery. The immunonutrition supplement available to us is called Ensure Surgical Oral Supplement, and the CEAA supplement is called Juven. Additionally, all the vitamin and mineral supplements I mentioned, including K2, are available in our system to prescribe at time of discharge. So in summary, published evidence supports the use of perioperative nutrition to enhance recovery after surgery and decrease post-op complications and hospital length of stay. It is feasible to provide our patients with some sort of nutritional supplementation, even in the setting of non-elective surgery. And I hope you'll consider it for all of your patients moving forward, regardless of baseline nutritional status. While further investigation is needed to elucidate the clinical effects of micronutrient supplementation in the post-op period, these supplements are low cost and generally low risk. If the potential for increased risk of cardiac events with calcium supplementation starts to make you lose sleep at night, consider adding vitamin K2 to your patient's post-op supplement regimen. I'd like to give a special thanks to the people listed here. And I'll now take questions.
That's great, Olivia. Thank you. I see. I was hoping that Dr. Shu was going to be on, so we could hear from him. I know that it's good that we're looking at this very at-risk population. You correctly identified them as being one of these difficult populations that you really can't do anything about. They tend to not show up for their pre-trauma clinic. Dr. Shu, any comments?
Yeah, I think one of the main purposes of choosing this patient population to highlight is that I think we've all been a little bit cynical over the years, as have I, that you really couldn't intervene on nutrition and make a difference. And actually the data shows that even acute intervention in nutrition, even if it's just in the post-operative period, decreases complication rates. And so I think that that's really a tremendous gift to the literature and really potentially practice changing for all of us, regardless of the type of surgery that you do. Obviously, the elective stuff is a little bit easier. You can start loading that nutrition in advance, but we can follow different markers. But the fact of the matter is the ultimate outcome measures have actually been moved. And so I think that that's worthwhile. And it's a really low cost intervention. I don't know if Sarah Bender's on or any of our CNSA colleagues, but it might be worth seeing if they can share their early experience with this, because we're really leveraging that pathway that they've developed to help spread this across MSK.
Joe and Olivia, I'm not sure that Sarah's on, but we're opening a new preoperative screening and optimization program up at Kenilworth, and I wonder if this could be part of the programming for that for the more elective cases. Any thoughts on that?
Absolutely, Olivia, you've got the most review of the literature in the preoperative setting. What would you suggest?
Yeah, so as part of the ERAS protocol, most people are loading them with immunonutrition for about a week before surgery, and then giving them those Ensure pre-surgery drinks to drink 2 bottles the night before, and then one the day of surgery, about 2 hours before. And that's been shown to sort of combat the metabolic response to surgery, and then also sort of supplement or ramp up their immunonutrition prior to surgery, and then give it to them again in the post-op period.
Let me ask you a quick question about, I think we had this similar concepts when we looked at perioperative glucose control, in the last decade, and noticed that was making a difference in outcomes as well. Do we have to make any special accommodations with these pathways for the diabetic patient? Because obviously I know it's a complex carbohydrate, but it's still a carbohydrate load for somebody who may be at risk of issues with that.
Yeah, and I think I mentioned it in one of my slides, but most of the studies have been in non-diabetic patients. There has been more recent literature showing that it's safe to give in diabetic patients, but the effects of I guess sensitizing the insulin response is not as well known